You can sit over there. So
So
sit over there. And
I'm going to get our session started here. I'm Yalini Vigneswaran from University of Chicago. I'm a surgeon. That's my only disclosure for this topic. We are going to be discussing the nuances of reflux and bariatric procedures. We're going to have a little bit of case discussion to start the session, and then we're going to move into some more structured talks and end with some discussion again of cases, and hopefully get some interactive discussions with the audience. So we're going to start off. John Pandolfino from Northwestern is going to introduce the session with his case.
all right. Well, thank you very much. First off, I just want to congratulate the AFS on an unbelievable meeting. This is the most fun I've had at a meeting ever. Throwing axes and lumberjacking and then playing hoops with my former trainees was pretty awesome. So I want to congratulate you on a great course, fun and educational. So these are actually topics that I think are probably one of the most difficult cases that we see in an esophagology clinic. And this is a case that was sent to me a few years ago. Patient with dysphagia, reflux regurgitation in the context of a prior gastric sleeve. Now, the patient was a 69-year-old female with hypertension, had a prior gastric sleeve, and was referred for evaluation of reflux, cough, and possible achalasia. And once again, when you hear possible achalasia in the context of a previous surgery, whether it's bariatric or anti-reflux surgery, your first thing you should be thinking about is pseudoachalasia. It's very rare. I think Mike brought up Occam's razor. Very rare to get that very rare disease in the context of a surgery and have it be a de novo true achalasia. So this particular patient, was really more conscious of the reflux and the regurgitation, but food wasn't staying down, felt a burning sensation almost always, especially at night, and felt acid regurgitation. She slept in an elevated position and was following most of the stuff that she was supposed to do, not eat 3 hours before bed. She did feel like she was aspirating a little bit, and that's where people were getting very concerned. There's her past medical surgical history. Gastric sleeve obviously is the big thing. And of course, just like everybody, this patient was on a high-dose PPI twice a day. So these were some of the studies that this patient had. And you can see the high-resolution manometry, which was actually the first study that was done, which I probably would not have done. And this was a representative esophagram. So what do people think about that esophagram? Do they think that is an achalasia esophagram? Do they think that is something else? Yeah, so this came to us, this is achalasia, hugely dilated esophagus, and you can clearly see that there's a hernia. You can actually see if I get my laser pointer. You can see the little pinch there. And you have to realize when you're doing these studies and you have these catheters that try to snake their way around these curves, they're going to have pressure sensor signals that are not real, right? So on that high resolution manometry, they had an elevated IRP, and really that was mostly right here, and it was really related to kinking of the catheter. So if you change the position around, that would actually normalize. But this is a pretty classic presentation that we see quite often in our clinic, this diagnosis of achalasia in the context of bariatric surgery. So this was the endoscopy that the patient had. You can clearly see that there is some dilatation and there is a little frothy secretion, but it's not sitting in the esophagus. It's actually sitting within the sleeve, and you can see the retroflect view. And I think it's an important process when you're doing endoscopy in these patients and you're getting your landmarks and noting where those landmarks are. If your sphincter is at the 32 centimeter mark, that's probably not at the crura. There's probably herniation there. So anything you're seeing below that is likely stomach. In addition, when you assess these patients, especially gastric bypass patients, most of those patients, their sphincter is completely blown out. Like you literally go down and you can't even tell that there's a sphincter anymore, and the area of obstruction is usually in the gastric pouch as opposed to this. And this is why, always consider that this is pseudoachalasia. So this was the flip, and once again, you know, the flip is looking at obstruction and diameter, and a kink and a turn can actually give you a little bit of an obstruction. So this is actually a pretty borderline, but borderline normal study. The DI is around 4.0, and the max diameters are about 13 to 14. That's actually pretty good in this situation. That being said, you know, the patient does have absent contractile response and absent peristalsis, and that's likely a manifestation of chronic obstruction. So this particular patient went to the OR and actually had a hernia repair with a conversion to gastric bypass. And actually 2 years later is doing quite well. And you know, there's not a lot of great data when you actually look at this patient group of achalasia pattern or pseudoachalasia after bariatric surgery. And there was actually a very nice experience by Karthik Ravi that was published in the Red Journal that looked at this in consecutive patients who presented with clinically significant dysphagia. So once again, a highly biased group that you'd see this. And in their study, they saw that about 12.4% or 13% of these patients actually had a pattern that was consistent with achalasia, but did not have that pattern preoperatively. And I think that's really the most important. They came up with this kind of term post-operative dysphagia or esophageal dysfunction in patients with bariatric procedures. But I think this is still just pseudoachalasia in the context of bariatric surgery. So the hypothesized reason for this is that these patients have a chronic obstruction that eventually leads to essentially the esophagus giving up. And they dilate, and eventually they look like they have achalasia. Still not proven. There's not a lot of morphologic detail to support that. But certainly that is a reasonable, plausible, or biologically plausible reason to get this. Now, the one thing I will tell you that as I was perusing my email, there were a conversation going on about POEM in these patients. And I will tell you, that's my nightmare. When I see these patients post-POEM, you've literally just created an animal model for reflux. So, you know, in these particular patients, be very careful when that question, so I know I think it was Steve Leeds was started or triggered the discussion over the email regarding POEM in this patient population. I'm not saying that it never occurs, because you can never say never, and you can probably see maybe an achalasia patient, you know, every once in a blue moon who had this procedure and may benefit from a myotomy, but most of these patients actually will not, and they will actually get worse with that particular procedure. So that's one of the things I think we need to take home from this particular case. So we're going to open it up for any questions. Yelena, you have any?
So I think, you know, one point just to clarify too is although achalasia is rare after bariatric surgery, we do have patients that present with achalasia and morbid obesity. And in those patients, they can benefit from a myotomy with a combined bariatric procedure. But I totally agree with you. I think a lot of times in these patients it can be confusing if you don't better understand the underlying motility issue, which is related to the bariatric surgery anatomy.
Yeah, and obviously doing a POEM in that particular patient would not be a good idea.
Yeah.
Because once again, you're creating another animal model with very high intergastric pressures and a sphincter that's incompetent. Barham?
Thanks, John. Excellent case presentation. It's interesting. The case that you showed clearly had a mechanical outflow obstruction, which is the paraesophageal hernia, which is slightly different than post-SIT or post-obesity surgery esophageal dysfunction, that you do not see any functional anatomical disruption. That means you don't see outflow obstruction on esophagogram or even on high-resolution manometry. What you see is decrease in the compliance of the proximal stomach, creating a pseudo outflow obstruction with increased pressure. So when we started doing in the flips on a lot of these patients, the secondary peristalsis goes away and they develop this retrograde contraction and aperistalsis before you see differences on high-resolution manometry. So it's an evolving story. It's a very interesting one. But we should differentiate between a functional or anatomical outflow obstruction and a functional one. Because if it's a functional one, you just go to a smaller conduit, which is you go to gastric bypass. Versus the paraesophageal hernia, you fix the paraesophageal hernia.
Yeah, and I think that's a good point. I think we've seen the repetitive retrograde contraction, and it's really important to realize that that's not pathognomonic for spasm. If there is a distal obstruction or a post-sphincter obstruction, the esophagus is not that dumb. It'll actually try to go backwards and push backwards. And it goes at that rate of 12 because there's no inhibition backward. So you don't have that descending inhibition, and you can get that rate.
Just a comment, John. You mentioned that the manometry was done before even the scope or the barium. And I see this often. We always say that motility disorders need to be diagnosed after a mechanical cause has been ruled out. So this type of issue is actually quite common, unfortunately, and we need to make sure that they get the scope, they get the barium, because at that point, you might not have even thought of achalasia once you already knew that there was the hernia and the anatomical disruption.
Yeah, I certainly think that the order of testing in this case was not the best way to do this, but in the end, the patient got the right diagnosis and the right procedure and is doing well. So.
All right, you want to move on?
Any other questions? No. Okay. Well, we are going to move on. So now we'll talk about the appropriate workup and the workup tips for these particular patients with Shelby Sullivan, who now is at Dartmouth and is in gastroenterology. I'll sit with you.
Don't leave me solo.
Much, and thanks for inviting me to give this talk today. And I think, do we have a thank you? All right. Here are my disclosures. I mostly work with companies that are doing endoscopic bariatric therapies. So there are lots, so I'm really going to focus on these surgeries. I'm not really going to talk much about lap band during and workup of reflux before lap band during this talk. And again, this talk is really about what you should do for workup prior to a surgery or an endoscopic bariatric therapy procedure, not really focusing on what happens after the procedure and working it up afterwards. So what you can see here is I've kind of bundled these together a little bit in this slide. We've got the Orbera balloon, ESG, and Roux-en-Y gastric bypass. And kind of on the other side of the slide, you see multiple surgeries. The most common surgery in the US really is the sleeve gastrectomy, but then we also have pileo-pancreatic diversion, single anastomosis, duodenal ileal bypass, or the SOD-S. And then there's lots of other bariatric surgeries as well, but these are kind of the ones that I'm focusing on. But what you can see is that the three surgeries that are on the one side of your slide, on the slide here, really all include sleeve gastrectomies. And why is this important? Because when we're really thinking about the pathophysiology and the anatomy around the esophagus, and part of what helps keep the esophagus closed, we really think about, there's obviously multiple contributing factors to reflux, but certainly the anatomy is associated with it as well. And when we have a sleeve gastrectomy, we have disruption of the sling fibers and tubularization of the stomach. So you're turning that stomach from a big bag into a sleeve, increasing the pressure overall in there. With the Roux-en-Y gastric bypass, you're not really disrupting the sling fibers, and the surgeons can correct me with this if they disagree with that. But then in addition to that, it's not a really high pressure system. You're really turning that into a low pressure system as well. With endoscopic sleeve gastroplasty, we're suturing in the gastric body, but we're leaving the fundus open. We're not disrupting any of the other anatomical mechanisms that control the closing of the lower esophageal sphincter, although there is some delayed gastric emptying that occurs. Same thing is true for the intragastric balloon. There's also delayed gastric emptying, again, that may cause more food to be left in the stomach. But the other thing is that with the intragastric balloon, especially the fluid-filled intragastric balloon, we may have some increased pressure below the GE junction, especially if that balloon is sitting more up in the body or the fundus of the stomach. So what about, I'm just going to touch on GERD and bariatric surgeries and the effect on surgery, effective surgery on GERD. And the reason why I'm touching on this is because it leads into this, this discussion on what you should do before the surgery. So de novo GERD, 25 to 40% of sleeve gastrectomy patients, not as much as in Roux-en-Y gastric bypass patients, although it still can happen. De novo Barrett's esophagus, 4.8 to 18.8% of patients, 3 to 10 years after sleeve gastrectomy. There's a couple of meta-analyses now that have looked at this. And then in the position statement of the ASMBS, is to consider EGD preoperatively in all patients. But this is at the surgeon's discretion, and it's not an all-out recommendation that you have to do it for everybody. And why is this important? Why would you consider doing it? So in a meta-analysis looking at pre-surgery EGDs, we see that most patients had a normal EGD before bariatric surgery. There was about 25% of patients that had an abnormal EGD, but didn't change the surgery or what they were going to do. But there was a change in approach with about 15% of patients, and less than 1% of patients had an absolute contraindication to bariatric surgery because of that upper endoscopy. And what about correlation between preoperative GERD and findings on evaluation? And I think this really comes down to like, what should the evaluation be? Because in this study, looking at 200 patients, and this is kind of controversial on like, how does this really correlate? But in 200 patients who underwent a screening evaluation for symptoms, they had two groups. One was an asymptomatic group and one was a symptomatic group. And it's important to note that there was reflux that was previously diagnosed and treated in both of these groups. So in group A, 43% of patients had medically treated GERD, and in group B, 66% had medically treated GERD. But when they actually did the evaluation, there was really no difference in esophagitis, Barrett's esophagus, or hiatal hernia that was noted in these groups, regardless of whether they were asymptomatic or symptomatic. And the positive screening really reduced the chance of patients undergoing sleeve gastrectomy compared with Roux-en-Y gastric bypass if they had more advanced esophagitis. So what about some of the endoscopic procedures? So we talked a little bit about laparoscopic sleeve gastrectomy already. What about ESG in terms of what happens after the procedure in terms of reflux? So this is a meta-analysis that included 7 studies, almost 7,000 patients. Weight loss at 24 months was less in the ESG group versus the laparoscopic sleeve gastrectomy group, but you can see that reflux is significantly less in the ESG group versus the sleeve gastrectomy group. So less than 2%, it was about 1.4% in the ESG group versus about 18% in the sleeve gastrectomy group. So we don't see as much of this as a problem in the endoscopic sleeve versus the surgical sleeve. What about intragastric balloons? So this is looking at the FDA trials and the adverse events that were reported in the FDA trials in the United States. And what you can see is that with some of the balloons, especially the balloons that are more commonly used right now, including the Orbera balloon, that there's a pretty high rate of reflux in these trials, so up to 30%. So it's definitely something that you want to think about in patients who may have GERD before you even go down the pathway of offering an intragastric balloon to them. So who should be screened? And first, we always have to think about Barrett's esophagus, right? Because when we look at any of the guidelines for screening for Barrett's esophagus, one of the biggest contributors that we should think about in terms of risk factors is obesity. And so this is the population that we're looking at. And in each one of these guidelines, obesity is a risk factor that would lead to Barrett's esophagus screening. So first and foremost, for any patient undergoing a bariatric, endoscopic, or surgical procedure, screen for Barrett's esophagus when it's indicated, and always do that regardless of what the procedure is that you're going to do. Recently, guidelines came out from the International Society of the Diseases of the Esophagus, and this guideline really recommended preoperative EGD for all patients undergoing bariatric surgeries. They recommended identification and repair of hiatal hernias greater than 2 centimeters, and they recommended that an esophagram should not be used for diagnosis of GERD, but can be used to verify hiatal hernias. They also broke down typical and atypical GERD symptoms, and with typical GERD symptoms, they said to consider further evaluation with pH impedance to help with choosing in between laparoscopic sleeve gastrectomy and Roux-en-Y gastric bypass, but it's important that there is not a hard and fast recommendation against laparoscopic sleeve gastrectomy in patients who have reflux. So it really kind of depends on the severity of the reflux, whether or not you can repair a hiatal hernia before those with that surgery. And for atypical GERD, again, considering the pH impedance to help with choosing between the two. And they also warned that really in this population, we do kind of more consistently see symptoms worsen after laparoscopic sleeve gastrectomy in this atypical GERD group. And of course, for any patient who has dysphagia, they should be getting before a surgical procedure, a high resolution manometry, if they are having dysphagia in addition to that endoscopic evaluation. There we go. What about for endoscopic procedures? So there aren't clear guidelines for this at this point. For intragastric balloons, if you're doing a fluid-filled intragastric balloon that's endoscopically placed, you are automatically going to be doing an endoscopy because you have to do it to place it. If you're doing a swallowable balloon, you're still doing a barium esophagram prior to that procedure. And again, the rule still applies that if that patient has symptoms that are consistent and or are other risk factors for Barrett's esophagus, even if you're doing a swallowable balloon, you'd want to evaluate that before you did a swallowable intragastric balloon. In the US, there are no current swallowable intragastric balloons that are commercially available. There is one that's still FDA approved, one that's undergoing FDA trial, but currently none are available commercially. The other things to consider are avoid placement, again, in patients who already have poorly controlled GERD at baseline. Although we don't have guidelines for this, it's my experience that those patients are just going to get worse with a balloon in place, and in many cases, you're going to have to take that balloon out early. In terms of the hiatal hernia, you do want to avoid a hiatal hernia greater than 5 centimeters. For the swallowable gas-filled balloon, that's greater than 2 centimeters. And again, avoid in placement in patients who already have more advanced esophagitis. For ESG, again, you're going to be doing an endoscopy when you're doing that procedure. If you see a large hiatal hernia, you really want to consider whether or not you want to proceed with that ESG. You may want to stop and actually treat that hiatal hernia before you do the ESG. Although again, ESG is not associated with significant reflux after the procedure. So in conclusion, the population seeking bariatric surgery or bariatric endoscopy are already at high risk for Barrett's esophagus. So we really should be thinking about screening those patients if needed. And then in terms of GERD risk, higher after sleeve gastrectomy and intragastric balloons, lower after Roux-en-Y gastric bypass or endoscopic sleeve gastroplasty. Recent guidelines recommend doing an evaluation in all patients before surgery, and you should still consider this for GERD evaluation for both intragastric balloons and endoscopic sleeve gastroplasty as well. That's it.
So real quick before we bring up our next speaker, Eric, you can start. Eric Wilson, who is the Director of Bariatric Surgery at the Memorial Hermann Texas Medical Center, will come up. How many people in the audience are not either performing or getting an upper endoscopy before a bariatric procedure? All right, great. So we have no room to move, so no room to improve. So now at least we can hear what to do after someone develops severe reflux.
All right, thanks, John. Again, thanks to the AFS for letting me talk. I have lots of disclosures, so much that I'm probably conflicted in my own existence. But I got 10 minutes, and I'll try to be as provocative as I possibly can, so we'll light this candle. We know that we need to tailor GERD treatment. It's a progressive and variable disease. Same thing for obesity. We need to tailor it. Shelby did a good job of talking about endoluminal procedures. The surgical procedures that are out there that are the common accepted ones are variations off of these 4. Bariatric surgery, one of my soapboxes is bariatric surgery always loves to kind of have the favorite, and it drives me crazy. Right now it's sleeve gastrectomy, but if you look at the history of bariatric surgery, there's always been one that's been a market leader, and that's a problem because it's a complicated, complex disease. It's like saying we only need one operation for reflux, and it just doesn't make sense to me. But right now it's sleeve gastrectomy, and sleeve gastrectomy has some significant reflux issues with it. Why is it sleeve gastrectomy? Because it's easier to do than a bypass, and maybe someday we'll all be comfortable in the bariatric community doing anastomotic cases. We all know reflux is complicated. We know it's an incompetence of the sphincter. It has aspects of the muscle and the flap valve and the hiatal hernia. Those all are important components. We all know that. We also know it's a function of how well we clear above and below it. So we know it's complicated. We also know that doing bypass really does a good job with it. There's lots of old data around that. This is one from 2002. This is one that looked at esophageal and gastric failure and compared, it's a very small study, but a very old study, 2007, compared even esophagectomy versus bypass and Nissen, and bypass was the best. I mean, it had the least amount of dysphagia and the best reflux control. This is a very old study from 1984 comparing Nissen to bypass with severe GERD, and bypass was better in those patients, even doing them open. This is more recent data, looking at bypass versus fundoplication, and you had superior resolution of GERD symptoms and dysphagia with bypass over recurrent or failed anti-reflux surgery. So if you have a failed anti-reflux surgery, what do? Do you bypass on them or a recurrent anti-reflux operation? If they have obesity, I think there's a good amount of data to support. If the BMI is over 35, we should just offer them a bypass. I know that that's still controversial. Again, recurrent reflux after failed surgery. Another old study showed that significant better quality of life and better resolution of reflux symptoms with bypass. So it goes beyond of what causes GERD. So it takes a bad valve, but the other thing, the reason bypass works so well is it also takes a volume of refluxate. Something has to exist, a reservoir has to exist below the valve to reflux. And if you don't have a reservoir, you can't reflux, at least not much. And what a bypass does better than anything is if you do it right and you make it small and you attach a piece of intestine that acts as a sump tube, you negate the volume. There's no volume there. So when a patient has reflux and they have a gastric bypass, which does occur, that does happen. If you take bypass patients and look at them 10 years out, about a third of them end up on anti-reflux medications. But then you start studying them, not all of those have reflux. A lot of them end up being back on PPIs for other reasons. But if that's the case, and they truly have reflux, you do a pH probe and you find reflux, and you can find those patients, you got to go find the volume. Why is something sitting there and regurgitating up? Why is it not draining down? And so you've got to look for distal obstructions. Is there internal hernia? Or there's some type of adhesive problem of the roux limb, or some functional problem of the outlet of the roux limb, or an intussusception. Sometimes they have large or non-functional gastric pouches. You'll see this sometimes in patients who've had previous lap band, then converted to sleeve gastrectomy, and then converted to gastric bypass. So they've had lots of pseudoachalasia type environment for their esophagus. Their esophagus and pouch no longer work. It's dilated, either functionally or truly anatomically. That can create a reservoir effect with or without a hiatal hernia. Certainly a gastric fistula creates a reservoir effect. A large candy cane, that is debatable, but if you have a large blind end of your roux limb, that can act as a reservoir effect. And certainly a shorter roux limb could be an issue. And a lot of these patients have marginal ulcers. They say, I've got reflux, you scope them, you find a marginal ulcer. You need to treat the marginal ulcer. In some patients, they're severely overeating, and you need to get them to slow down and work on their behavior. So those are the things you need to think about when you're thinking about reflux, especially in managing the patients when you're going to consider converting them to gastric bypass, but also when you're dealing with a patient that has quote-unquote bypass. Sleeves. So, sleeves are the most popular, so I'm going to rag on them. That's what I do. Whatever's the most popular, I'm going to rag on. It has chronic leak issues. GERD is definitely a problem, and there is weight regain compared to some of the better procedures like bypass and duodenal switch. I do sleeves. I think they're a great operation. I just don't think we should do them at 60-70% of the population. There's a good amount of data. Shelby already talked about this. There's a significant amount of patients that get de novo reflux after sleeve gastrectomy and some de novo Barrett's. You can look at the numbers. I don't know exactly how high it is, but it is a real thing. People do get Barrett's esophagus after reflux. There's probably a component to bile to that. We all know that Barrett's bile, it's not just about acid, it's about acid and bile is a component of that. And so when you start talking about the complexity of reflux and then you add in this anatomy of sleeve gastrectomy, you just make it that much more complicated, because you add in a change in the angle of His, potentially on how you create the upper part of the sleeve. You change the incisura, and with a tight incisura, you can create lots of true mechanical obstructions, or based upon angulation, you can create a functional obstruction. You can see these mechanical obstructions if you drop an achalasia balloon down when you work up a sleeve patient that has reflux. Drop a 35 achalasia balloon across the incisura, inflate it. If it doesn't waste, it's probably not a mechanical obstruction. It could still be a functional obstruction. Gaseous CT scans or Physi-CTs can often show that at the incisura. And then you also potentially make the pylorus incompetent based upon how the patient responds to that. And you've got a tube attached to a tube. So, when I'm working up a patient, I'm trying to figure out, I scope them, I'm looking for a biocomponent. Is the incisura functionally narrowed or truly narrowed? And then, so I start with an EGD with a Bravo and a 35 millimeter achalasia balloon. That's my first test to work up a sleeve reflux patient, and we get a lot of them. The same issue applies because it is a sleeve gastrectomy with duodenal switch and reflux. A classic duodenal switch, because it has a roux, is a little bit better from an anti-reflux perspective than a looped version, and we're going to have more and more looped gastric bypasses out there with more bile reflux, and looped duodenal switches also have some bile reflux component, and you need to know that. Shelby already went over the bariatric therapies. She said that reflux and balloons do have reflux. They do. It's been studied. Interesting though, ESG, it doesn't. This is Barham's data on looking, and it does delay gastric emptying, but we tend to not have enough delayed gastric emptying that it creates a functional or a true obstruction at the incisura. At least in the current forms of what we do is ESG. We're getting more aggressive with ESG, and with some of these mucosectomy versions and in more aggressive plications, we might start to see that at some point in time, but we're not seeing it yet, and this is the MERIT trial data that showed an improvement of reflux, which is probably a weight loss effect. That being said, and Sai's going to talk about endoluminal stuff. If you can reduce the volume endoluminally, there's some benefit potentially if it's just a basic dilation of a pouch or an upper sleeve. An endoluminal plication can potentially help patients with reflux. If they have a fistula, you can address it endoluminally. Sometimes they recur, and so I do that as well. So there are patients that I will address just endoluminally if they don't have a big hiatal hernia and they don't see any other major issues, and I'm just trying to improve the outflow out of the upper stomach. So, this is a complex problem. We should be adept at bandaging both obesity and reflux together. Weight-induced GERD generally improves with all weight loss procedures, but a gastric bypass with a small pouch is probably the best anti-reflux mechanism because it takes away the volume. If a patient has reflux with a bypass, something is likely wrong. You got to go figure out where the volume of refluxate exists. And well-constructed roux limbs divert bile and refluxate volume, and is more reduced with roux forms versus loop forms. And so when we see more of these loop forms coming out, it adds to the complexity of it. So, I think long-term strategies for reflux should focus on supporting the valve and reducing the refluxate. Well-constructed small bowel gastric bypass is an important operation for bariatric and foregut surgeons. So there's a few examples. Your BMI over 35 and you have GERD, bypass should be up there. It's going to be in the top of the discussion. 2 failed previous anti-reflux surgeries. You can pick your number. Mine's 2. After 2, I'm talking bypass really aggressively, okay? GERD and severe esophageal gastric dysmotility, especially if they're together, bypass is a big issue. And it's not perfect. You sometimes end up trading symptoms when you do this, and you have to warn the patients about that, but it's an important aspect of care. Thank you.
Do you want to ask that question? Or?
You can ask it if you have it up.
All right, before Yelini introduces our next speaker, you can still come up.
Yeah.
There was one question. We've been perusing the Q&A, and someone asked about hiatal hernia. Like, what is the real data to repair these small hernias during these bariatric surgical procedures?
So I think we actually did a randomized trial on small, it's interesting you asked that question, John. A randomized trial about 10 years ago on small hiatal hernias and sleeve gastrectomy, because we really thought that even the small ones were going to need to be repaired. And at the first 3 months, we could see a difference. Beyond that, up to 5 years, it really shows no difference for small. So the reality is, because it's a tube attached to the tube, if you do a full dissection, full hiatal mobilization, which is what we did, there were other people that were just doing small plications and not really mobilizing. But if you do a full dissection, a mildly incompetent esophagophrenic ligament is probably better than no ligament, or at least it's equivalent when you do it. So I think you need to evaluate your hiatal hernias very, very carefully. But if they're 2 centimeters in width or axial displacement or less, then I think you need to not always necessarily repair them. It doesn't make it significantly worse, but the interesting thing about that study is that we realized that there's a whole bunch of patients that we do sleeve gastrectomy on, their reflux gets better on, and then there's this de novo percentage of patients that it gets worse on, and we can't predict who that is. We're not good at predicting it. And it's probably because we're not good at predicting on how each patient responds to those changes in the physiology of the stomach with the anatomic changes we give it with the incisura and the stapling at the top and at the bottom.
Well, yeah, I mean, it's to the point of what is the pathology of the reflux, and oftentimes it's the weight and the metabolic syndrome and obesity itself. And I think the other point about fixing these hiatal hernias at the time of surgery, it's easy when you have a BMI of 40 or 45, but to do a real extensive mediastinal dissection and adequate hiatal hernia repair when you're dealing with a BMI of 60 or 70, it's not the same ball game, probably not safe one, to getting that liver up to do an adequate dissection is impossible. And so to your point, if it's a small hiatal hernia, putting the patient at risk and doing an inadequate repair is probably not appropriate. But I think there's so much nuance in this whole topic.
Yeah, and I'm a big preoperative endoscopy believer, like most of us up here, I think. And I think you can have that discussion based upon a good preoperative evaluation of the hiatus, and then talk to the patient about it.
Hence the title, Nuance. All right.
Yeah. So I am happy to introduce Lena Kaitan, who needs no introduction, but from University of Hospitals in Cleveland, Ohio. She's been a leader in helping us better understand the role of magnetic sphincter augmentation after bariatric surgery.
Thank you. Thank you all so much for the opportunity to come speak to you all. And this is a topic that's near and dear to my heart, and I've really loved all the talks of the prior speakers, and it really plays in a lot to what you're going to hear from me. And I'm going to, I have disclosures to share, but my biggest disclosure is I'm a foregut surgeon, I'm a bariatric surgeon, and these are all my opinions. But I think I'm starting to put some data behind it, so I'm excited to share some of this with you today. So as we heard from all the speakers, reflux after sleeve is a well-accepted phenomenon, right? Since the RELIEF study was published, now we know that MSA is an acceptable management strategy for GERD after sleeve, but how do you choose that right patient? And I'm going to focus on sleeve because Eric gave such a great talk on bypass, but you can apply a lot of the algorithm that I'm going to share with you today to any bariatric procedure. And I'm going to go through with you, how do we choose that right patient and what is the latest data? Because that's what we're talking about here. I think that's what kind of all of our speakers so far have set us up for this. So the first actual report on MSA on a sleeve was by Dr. Ben David in 2015. And I started putting MSA in around 2013 and then started using it on my sleeve patients right around that time because I was like, I don't have a strategy for the LES, in these patients. I don't have a fundus. Why don't I try throwing the links on there, see what happens, So over the last almost decade of experience, I'm going to share with you kind of what I've learned. So, why do we see so much reflux? And you've heard all this in the prior talk, so I'm not really going to go into all those questions because those have already been presented. So what I'm going to share with you is how I try to make sense of it. And I'd love to hear everyone's feedback about it because there's a million papers out there. The writing's too small to say that sleeve worsens reflux. But to Dr. Wilson's point, we also know that there's a group of patients who actually do well with a sleeve gastrectomy and their reflux goes away. So how do we distinguish who those patients are going to be? And I think that there's a lot that goes into it. And I think it's really interesting when you look at this paper that was by Drs. Altieri and Pryor, and you look at mechanisms of reflux after a sleeve. One of the most interesting thing is that almost everything that you see on here has to do with that sleeve shape, all that Eric brought up about what we make our sleeves look like. So maybe a lot of the reflux that we're seeing is our fault. Maybe we're causing some of it with what we're doing, and maybe we need to make better sleeves. That's actually, one thing that I think is out there. But most of these things relate to sleeve morphology, and the contribution of the LES when we talk about reflux in anybody with unaltered gastric anatomy, the crura, isn't even a part of the discussion. It's like one thing on here. Everything else has everything to do with the sleeve morphology. Same thing about how to avoid reflux after a sleeve. Same thing. Pretty much everything has to do with sleeve morphology. So I think that's really, really interesting when we look at these different reviews and we're trying to wrap our heads around why is the sleeve such a refluxogenic operation. So in unaltered anatomy, we come to this meeting, we talk about reflux, we talk about LES dysfunction, we talk about hiatal hernia, talk about patient factors, lifestyle factors. With altered gastric anatomy, we have all those things, but a big part of it is that sleeve morphology. And the lifestyle factors for these bariatric patients plays in even more, because all of these people came in to have weight loss. They had a weight loss operation. So their weight, their lifestyle, the types of foods they eat has to be a part of the conversation as well. Because we know that there's a lot, the mechanism of reflux has a lot of things that go into it. So this is where we need to think with all of our hats, right? When we're a bariatric surgeon, we have a lot of things in our toolbox. Gastric sleeve, bypass, all the different procedures you heard about. When we're a foregut surgeon, we're thinking about hiatal hernia repair, plications, endoscopic procedures. Okay, but I borrowed this slide from my friend Krista Coyne because I love this slide. We call this leveling up, right? You need to put both hats on when we're thinking about reflux in these patients. We need to have our foregut hat on, we need to have our bariatric hat on, and put this all together. And so this is something what I've done through my practice and trying to figure out how am I going to manage these patients and their reflux. So I just want to review a little bit of the RELIEF study. As you all know, this was to see if MSA in the sleeve population is safe and is it effective. And these patients were mostly middle-aged women, and mean BMI was 29.9. Preoperatively, all these patients had pre-op endoscopies. 70% were identified to have a hiatal hernia, but 90% had a concomitant hiatal hernia repair. The operative time was short, and there were very few intraoperative complications. pH normalization only occurred in 22% of patients. So this is where we got to think about what are we really trying to achieve when we're trying to do any kind of an anti-reflux procedure, right? Normalization or greater than 50% reduction was in 44%, and discontinuation of PPIs, however, was at 85%. And I think that was one of the biggest take-homes from the study. Reflux time improved, Demeester scores improved, but again, not normalized, but again, patient symptoms improved. Regurgitation went from 27 episodes a week down to 4 episodes a week, and patients were very satisfied with this procedure. There were no deaths, no reoperations, and the conclusion was that this is very safe to manage reflux after gastric surgery, and this is what led to this being FDA approved for the use in the sleeve patient. And so we looked at our outcomes with our patients post-sleeve, and we presented this at this past SAGES. And we also found that when we placed MSA in our patients, even at greater than 3-year follow-up, that their GERD-QOL scores are really good. Some patients do get back on medicines, but regurgitation was also minimal. So this is an algorithm that I've put together, and really what we're trying to take into account is all the factors that you heard about from all these speakers. How do we sequentially think about those things with our workup and then pick a management strategy? I know the writing's a little bit small, but first thing is optimizing the diet and the lifestyle. 50% of the patients who come to me with reflux after their sleeve, I can weed them out just by helping them modify their diet. Getting them off of what I call crappy food syndrome, CFS, is what I've termed it. You can fix their reflux. But then, now you got the rest, right? So if their BMI is still high, or if they have that abnormal sleeve shape, bypass, I agree with Eric, that's the way to go. Okay, but if they don't have a BMI over 35, if they have a good sleeve shape, then this is where we have some other options. So I work these patients up just like any other reflux patient. We're going to put them through all the things, the Bravo, the endoscopy, esophagram, all of that, but we're going to put all of that in context of their new surgical anatomy. And what does that mean, right? Because the esophagram allows us to look for all these anatomic abnormalities. This is what we don't want to see, right? Sleeve morphology, what we've heard about from Eric and from myself. You don't want to see a narrowing at the incisura. You don't want to see a big retained proximal pouch. You don't want to see maybe that functional obstruction like a big folded stomach. And you have to put all this together. Endoscopically, you also have to look at this. And again, you want to look for a good sleeve. When you're doing your endoscopy on the sleeve, you want to do 2 retroflections, not just in the proximal part looking at the hiatus, but you actually want to do one in the distal part of the sleeve so that you see in that panel number 12 at the bottom that it looks like a Hill 2 to 3 valve. Okay, there's nothing that hugs the scope at the incisura. If it hugs the scope at the incisura, it's too tight. That's part of the problem, and you need to fix that, and that's a conversion to a bypass. You want to confirm that there's actually reflux happening, so some sort of a pH evaluation. And then I like to do manometry in all these patients. It tells me about hiatal hernias, tells me about hypotensive LES, and I kind of use it as a surrogate in high resolution manometry. You can see that pressure distal to the sleeve. We don't have a great way to measure pressure within the sleeve with our current technology, but to me, when I see those big yellow stripes distal, I'm like, this person probably has a lot of pressure in their sleeve. It's popping over that sphincter. There's nothing I can do to that sphincter to make it any better. I got to decompress them, and that's where I'm going to convert them to a bypass. So what we did is we put our patients through this algorithm, and we had 64 patients, and only 41 actually got conversion to a bypass. And the rest had other options, all right? Either hiatal hernia with magnetic sphincter, hiatal hernia alone, RF ablation, or magnetic sphincter augmentation alone. And when we look at our follow-up, we have 5.8 years of follow-up now in these patients, and only 64% got converted, 36% were able to avoid a conversion. The BMIs in the conversion group was 41, 32 in the non-conversion group. GERD qual scores went from 39 to 12, and PPI use decreased significantly. So I think that, it's one way to look at this. There's a lot of different ways. I'm going to skip this video because we don't have a lot. I'm almost done with my time. But if we look at a literature review on MSA and sleeve, you'll see there's not a lot of papers out there. Follow-up is maybe 2 years. Our paper was the first one that was over 3 years. The RELIEF study was really the most robust study that's been done, looking at pH, GERD qual, daily PPI use, and everything. Most of them just look at the GERD quality of life scores. No matter which study you see with the MSA intervention, quality of life scores improves. And I think that's one of the most important things we are trying to achieve for patients is symptom control. So key aspects to work up for the magnetic sphincter augmentation. On the endoscopy, you're looking for those stenoses, particularly tight incisura. The esophagram, upper GI, you're looking for that morphology. You want to confirm the reflux. Manometrically, you want to make sure they have decent motility if you're going to use MSA. And emptying studies can be helpful selectively. Favorable characteristics for the MSA are that hockey stick morphology. That's really what we're kind of looking for. You want to confirm that the LES dysfunction is a part of their reflux. They have proven GERD. Unfavorable if they have that abnormal morphology, if they have a nickel allergy. Low LES pressures, what fell out in our long term, that those were the patients who ended up getting explanted. If their LES pressure was 4 or less, for whatever reason, in the long term, those patients were the ones who got their links removed. So at least in our experience thus far, that seems to be playing out like the patients who may not do well with it. And then the BMI over 35, I consider a precaution. These patients came in for weight loss to begin with, so we got to help them with that. And so that's got to be a part of the algorithm for management. So the MSA after sleeve is a great tool to have in your armamentarium. You just have to do it wisely. Patient selection, just like anything that we do as physicians, is really important. We got to address the patient factors because this is safe and it's effective if chosen wisely. So thank you very much.
For interest of time, we're going to keep moving forward. Sai Pitamol from Brigham and Women's Hospital is an advanced endoscopist and one of the leaders with the biggest series of endobariatrics in her practice, is going to talk to us about the role of endobariatrics.
Thank you so much, Yalini, and I would like to thank AFS organizers for having me here. It's such an honor. I love this meeting. I just love the fact that we bring GIs and surgeons together, very important for treating obesity, reflux, and all of the foregut diseases. And I'm very excited to be talking about bariatric endoscopy with some spin on acid reflux. So as of 2024, right now we have 5 endoscopic procedures and or devices that are available in the US, or Bara and Spas balloon, which usually result in about 10 to 12% total weight loss. Endoscopic gastric remodeling, which may be referred to as ESG post or endomina. Essentially, this procedure refers to when we use endoscopic suturing or plication devices to sew along the greater curvature of the stomach to reduce the volume by about 50 to 70%. And we're going to go over them in more details. So let's start with intragastric balloons, with the most common being the Obera balloon. So the Obera balloon is approved for patients with a BMI of 30 to 40. It's placed and removed endoscopically at 6 months. In terms of efficacy, with Obera balloon patients, a meta-analysis including 17 studies over 1,600 patients show that patients experience about 10% total weight loss at 1 year. So this was 6 months after balloon removal. From an SAE standpoint, we're looking at about 0.1% perforation rate and 0.08% mortality rate. In terms of procedure, this is a very simple procedure. We don't need to intubate the patient. It takes about 10 to 15 minutes. And you can see that we just pass a catheter into the patient's mouth, followed by an endoscope to make sure that the balloon is sitting inside the stomach. After that, we just inflate the balloon with normal saline and methylene blue. Depending on the patient's height and the stomach size, we usually put in about 500 to 700 cc of fluids. And once you're done, you just pull that catheter to detach the catheter from the balloon. So what about intragastric balloons and acid reflux? So we heard a little bit already from Dr. Sullivan's talk. In the Obera pivotal study, and Barham sitting here, he's one of the leads in that study. It's an RCT multi-center in the US, including 290 subjects. Of these, 160 patients received Obera balloon plus lifestyle modification. At the end of the study, which was 1 year after balloon placement, 30% of the patients in the balloon arm had acid reflux. So why is that? What's the mechanism of why patients with a balloon have acid reflux? So when you have a balloon sitting in the stomach, this can lead to distension of the fundus and gastric body. And this can cause a reduction in basal LES pressure and an increase in transient LES relaxation. And therefore, in the recent ASGE, ESGE guideline on bariatric endoscopy, while the guidelines recommend the use of an intragastric balloon for patients with obesity or those with a BMI of at least 27 with at least one comorbidity, the guidelines actually recommend the use of a PPI for the entire duration that the balloon is in place. So very important to educate the patients for this. Now let's move on to EGR, or endoscopic gastric remodeling. Currently in the US, we have 3 endoscopic suturing or plication devices that can be used to perform EGR: the overstitch suturing device and the IOP and endomina plication devices. The procedure associated with these devices are known as ESG, post, and endomina. In the bottom, you can see the videos, my procedure. You can see that the procedures are very similar, but you perform it using different devices. Essentially, we start at the incisor, and the goal here is to reduce the width of this incisor, ideally down to about 1 centimeter. And then after that, we start moving up to the gastric body and using either the suturing device or the plication device to reduce the length and also the width of the gastric body. And in all of these procedures, we spare the fundus. So we don't sew, we don't plicate the fundus. And the procedures, all of them are outpatient procedures. It takes about 1 hour to perform, and patients go home on the same day. So now, how much weight loss can we expect with EGR? Here's a MERIT trial run by Eric Wilson and Barham here. It's an RCT across the US, including 9 centers, including 208 subjects. At 1 year, patients experienced 13.6% total weight loss after the procedure. However, in the real world practice, we know that patients typically experience more weight loss compared to in a clinical setting. So in the recent ASGE, ESGE guideline, we conducted a meta-analysis including 21 observational studies with greater than 5,000 patients who underwent the EGR procedure. At 1 year, patients experienced 17.3% total weight loss. Additionally, we did a subgroup analysis by device types, which showed no difference in the amount of weight loss by devices. In terms of EGR and GERD, we heard a little bit already from Dr. Sullivan's talk. Here's a study from our group with Walter Shan at Brigham. It's a single-center study prospective, and we included 50 patients who underwent EGR. At baseline, about 44% had GERD, 39 patients, about 39% were on PPI, and then the rest were on H2 blocker. All of the patients completed a composite GERD questionnaire before and 12 months after the procedure, so the response rate was 100%. So what we found was that at 1 year, GERD-Q and RSI significantly improved. Additionally, we saw a trend towards significant improvement in the DSI score. And just to remind everyone, so GERD-Q is the questionnaire you use to diagnose GERD. DSI is to assess frequency and severity of dominant GERD symptoms, and the RSI score is to assess LPR or atypical symptoms. So we saw this in basically every speaker. We now know that sleeve gastrectomy is associated with acid reflux, and these are the possible mechanisms. But you can see that the reason why after EGR we do not see an increase in acid reflux is because we preserve the anatomy. There's no disruption in the angle of His, sling fibers are not resected, and the fundus is preserved. And that's probably the mechanism of why EGR is not associated with an increase in acid reflux symptoms. Another variation of bariatric endoscopic procedure is when we combine it with an endoscopic anti-reflux procedure. And we heard from Eric Wilson's talk that if patients have obesity with BMI greater than 35 and acid reflux, definitely refer them for Roux-en-Y gastric bypass. However, for patients with class 1 obesity, BMI 30 to 35 with acid reflux, we know that this is a challenging population to treat. Why is that? Number one, fundoplication is usually suboptimal when patients have obesity. Sleeve gastrectomy, we now know, can worsen symptoms of acid reflux, and Roux-en-Y is usually not recommended or performed in class 1 obesity. So one way to treat this patient population is to do a combined anti-reflux procedure and endoscopic bariatric procedure. In this case series, we use the IOP plication device where you can fully retroflex and then place plications along the LES and GE junction to help with the acid reflux. And then after that, during the same session, retroflex the transport and then do the post-procedure where we reduce the volume of the gastric body. I actually recently saw a patient that I did this procedure on 4 years ago, and she's still asymptomatic, not on PPI. Her weight loss was about 10%. Just from my experience, usually patients who got this procedure tend to do really well with acid reflux, but the weight loss might be a little less than if you were to do ESG or EGR alone. And more recently, we had a newer generation of the endoscopic suturing device, a single channel, which now can fully retroflex. So this may allow us to perform the same procedure with this device as well. With all of the current available evidence, the recent ASGE, ESGE guidelines now endorse the use of EGR plus lifestyle modification for patients with obesity or with a BMI of at least 27 with at least one comorbidity. Additionally, the guidelines also recommend short-term use of a PPI for this patient population, typically for the first 4 to 6 weeks after the procedure, but we don't need to put them on PPI long-term. In conclusion, currently available endoscopic bariatric procedures include intragastric balloons, endoscopic gastric remodeling, including ESG, POSE, and endomena. Balloons may worsen reflux symptoms, and PPI should be administered while the balloon is in place. However, endoscopic gastric remodeling improved acid reflux symptoms, likely due to preservation of the angle of His, sling fibers of the LES, and fundus. And last but not least, endoscopic bariatric procedures should be offered in a multidisciplinary care team approach. Thank you very much.
All right, since we're running a little bit close to overtime, we will just do a 5-minute discussion. We're going to keep it pretty quick. I did have slides. I don't know if I'll just put one case up, and if anybody has questions for the panel, please make your way to the mic and we can ask some quick questions. But I'm going to start with this one case and see what the panel thinks, okay? So we have a patient that has reflux symptoms, etc., after a history of sleeve gastrectomy about 10 years ago. He's on a BID PPI, but continuing to have breakthrough symptoms. His BMI is 34. And there's one more piece of information that I didn't put on here. He's on anti-obesity medications. And so I think it's something that we didn't bring up in the panel so far, but I think we're starting to see this more often. Some of our bariatric surgery patients are being put on anti-obesity medications as an adjuvant. And how does that affect their reflux? And how are you going to manage that patient? So this was his workup here. And so I'm just going to go down the row here and just quick answers about have you been seeing this and what do you do?
This is a pretty common, except for the GLP-1s. We don't get a lot of those yet with sleeve gastrectomy, but we certainly are seeing reflux in the GLP-1 patients. But yeah, this is one of the most common types of patients that I see in my practice is the sleeve refluxer, and those are patients that, you've got to figure out how bad is the reflux and then how bad of an issue is their weight. Alina's algorithm, I think, really kind of dives into it well. But, after they've had a sleeve gastrectomy and they have reflux, what do they hate most? Do they hate the reflux most? Do they hate where their weight is at? Are they equal? Because it determines which way I'm going to kind of flex as far as how aggressive to manage the reflux versus how much to do as it relates to their weight, and there's different choices based upon that.
Yeah, I think, I guess the other question, so this patient in particular, his workup pretty much showed minor esophageal motility disorder, which we see in all of our sleep patients, but he had pretty boggy stomach with a lot of retained material, obviously related to the GLP-1 therapy, but there was a previous sleeve, but it was a patchless stomach. So there's a couple options here on what you're going to do. I'll start with Dr. Sullivan. Yeah, what would you do?
I think that it really depends. So I usually, when I see these patients, think about whether or not, how bad their reflux is, how bad their esophagitis is, what their goals are of care. So some people say there's no way I'm going to no way I'm going to convert to a Roux-en-Y. And then I also look at that distal sleeve. I actually don't have access to I don't have fluoro in my room usually, so I will actually try to dilate these patients with EsoFlip. And have found, and so I'll do an endoflip first, see what the pressures look like, if they've got a distal sleeve stenosis.
Dilate, yeah, so this patient
and then dilate it. And this is patchless.
This
so
is
that's
a patchless stomach. It's the case we didn't really talk about today.
But I think for this particular patient, I mean, BMI of 34, but he's on GLP-1 receptor agonist. Reflux may be really related to that. I think I would consider coming off of the GLP-1 receptor agonist. If GERD goes away and weight goes back up, then I would say let's think about a conversion to a Roux-en-Y.
Yeah. Any other thoughts here? Sai, with your endobariatric therapy, do you approach these patients endoscopically?
Yeah, so similar to what Eric and Shelby said, I evaluated them for how bad their reflux is. And if their reflux is actually controlled on PPI, then I usually kind of advise them or offer them an option of endoscopic revision of sleeve gastrectomy. mainly to help with the obesity and bring down the weight. And usually for people whose reflux is controlled on PPI, the reflux will get better with an endoscopic weight loss procedure. And in my practice, I do both a suturing and plication technique, but for this patient population, I would use a suturing device and not plication device. In case in the future, if the patients need to get Roux-en-Y gastric bypass, it is easier for our surgeons to convert from sleeve to Roux-en-Y.
That's a real good point, because and the IOP is going to be more and more popular, but for revisional stuff, it has these nitinol baskets, and that sets up a potential real struggle for us if we need to ever staple across that. So, you know, the more simple suturing systems like Endomina and Overstitch, they're pretty easy to manage from a stapling standpoint. It's not like you can ignore those, you know, cinches, but the IOP platform with the nitinol baskets are something that we need to be thinking about where we're going to put those. And if you're burning bridges where you can't do a gastric pouch, that's a real problem for the future of the patient.
And I also think this patient has a little bit of a hiatal hernia there, maybe on that one
Yeah,
view.
possibly.
And the patient's on the GLP-1s because they want to lose more weight.
Yeah.
So it's almost like a no-brainer.
Yeah.
Like you fix the hiatal hernia and you convert them to a bypass
Yeah.
because the patient's looking for some more weight loss
Yeah.
anyway.
Yeah, agreed.
If they absolutely don't want to bypass, and I try to get to understand why people don't want to bypass, but Shelby's right. There are plenty of people that just don't.
Well, in my practice, it's usually the patient's a medical disaster, like this patient's a kidney transplant patient. And
Yeah, that's an
all
ally.
sorts
Or
of
what if
things.
they're a smoker
So,
and you
or
can't get them to
IBD
stop
or-
smoking?
Yeah, so there's
or-
sometimes
yeah,
some,
yeah.
reasons we can't give them a gastric bypass. I'll go to the mic for a quick question, and then we'll probably end the session soon.
Yeah, when we started doing sleeve, we were petrified of going close to the esophagus, so we left a little bit of a pouch up at the top, or a dog ear, then that dog ear dilated like crazy. Couple questions. Do you think the ESG, that fundus is going to dilate and you're going to get almost like a slip gastric band where you get a reservoir above that ESG? And number two, are you leaving more of a dog ear now that we know that we're dividing some of the fibers that may be controlling the LES? Or are you still sticking close to the...
So I personally still stick pretty. I want to be about a centimeter to a centimeter and a half off of the EG, off the angle of His. So I mean, I'm pretty close. I don't want to see a big dog ear. I think it does create a reservoir effect.
But then that's what the ESG does.
I'm sorry?
Isn't that what the ESG does then? I mean, why would we, if we're going to say...
An ESG, I mean, we're not able to get that tight in an ESG. I mean, as the devices get better and better at retroflexion, we'll see more of that potentially.
So
But
the leaving it then, the fact that, because I thought you used to get up there and get that, like triangulate stitch right at the fundus.
you
but
do
that's
make
not
attempts,
happening.
but you're really not able to get to the cardia at the angle of His with endoluminal plication at this point. I don't know, Sai, you have any opinion on that?
Yeah, and there's a study from Viv. Basically, he compared ESG, like two techniques of ESG, where he saw the fundus in one group and did not show the fundus in the other group, and he did not show any significant difference in terms of weight loss. And just from an anatomical reasons, we know that the fundus is thin and more vascular, so the risk of showing the fundus is higher. So you're just going to get more bleeding and more leak, and that's why in our practice we just don't show the fundus.
And the other thing to remember too is that, you know, we're slowing down gastric emptying with an ESG, so we actually want food to get stuck up there. And not only is it longer for food to get through, but you also have, you know, 80% of the ghrelin that's produced in your body is produced up in the fundus of the stomach. So we actually want food to get stuck up there, because that way, or at least have a delay in coming out, because that way that probably does act to suppress the secretion of ghrelin and reduce that hunger. So I think that it's still leaving it more compliant though. Like it's not as tight, and it has more compliance than you have after a sleeve gastrectomy.
I think it's a good.
Time it'll dilate, that's what I figured.
It's a good point, because obviously as a surgeon we're always worried about leaving retained fundus up there, and so I think it's something we may not be able to
True
solve
incissural
today,
narrowing
but-
with staples is significantly different than what we're doing with plication at this point. Now, we are getting more aggressive procedures. Sai's working on them, Barham's working on them, of, you know, mucosectomies and ESDs, and we may get to a point where the incisure is narrow enough where we actually can develop real reflux after these procedures. But it just hasn't happened yet, because I don't think it's creates enough true obstruction at the incisiura yet, but it
All right.
could happen.
I'm going to thank all of the speakers. Everyone had great talks and we had great discussion, and conclude for the day this